I'm going to talk a little bit about comparative effectiveness research just for a few minutes to lay a foundation for the conference today. But I also want to acknowledge the other partner institutions at our R24 infrastructure network. This is a collaboration with several institutions at Boston, and Roger Fielding is here from Tufts University, who heads up one of our cores, and then Spaulding Rehabilitation Hospital, and Ross Safant is a co-director of our R24, and so I want to thank them. And I also want to acknowledge Wendy Coster from Sargent College, who is heading up one of our cores as well. So there's a wide range of experience and talent in the room today, so we thought it would be useful just to do a quick review of comparative effectiveness research. And so I went to the IOM, which released a report in 2008 on this topic, and they put together, I thought, a very straightforward definition. Comparative effectiveness research, or CER, is the generation and the synthesis of evidence that compares both the benefits and the harms of alternative methods. And these are alternative methods not only for treatment, but also prevention and diagnosis, as well as monitoring various health conditions, or to improve the delivery of care. So it's a very broad range of research if you think about that definition and take it seriously. What the IOM argued in their report is that the whole aim of comparative effectiveness research was to assist consumers and clinicians and purchasers, as well as policymakers, to make more informed decisions, as Bob was just noting, that would ultimately improve the health care at the individual and the population level. So if you take that definition seriously and you think about what typically is done and funded by the NIH, it really pushes the envelope in what is traditionally supported by the National Institutes of Health, our major funder. And it really pushes us to think much more broadly about the research that needs to be done to improve the health of our population. And there are also several elements in the definition that I think are important to remember. It's not only the generation of evidence, it's also the synthesis and the dissemination of that evidence. It's obviously the direct comparison of different interventions, and it requires that we look at the potential harm as well as the potential benefit. All too frequently in our work, we focus on benefit and we ignore the harm part. It also includes the implicit and sometimes explicit acknowledgement that we should be studying patients who are typical of clinical care, and this raises design issues that our panel will, I'm sure, get into later this morning, as well as the identification of clinical characteristics that will predict which interventions would be most successful, not only for individual patients, but also for subpopulations of patients. Now, I have to admit, I do have a concern as I read the literature on comparative effectiveness research. The focus tends to be on specific clinical conditions. As someone who is very interested and has spent his career focusing on disability, I do get concerned that the emphasis is too much on clinical conditions and not enough on the consequences of clinical conditions and people with multiple clinical conditions and the challenges that doing research with individuals with these types of situations has. Many times these people are excluded from the kinds of research that we're talking about here. So I think it really creates some wonderful opportunities for those of us who are interested in disability-related comparative effectiveness research, but I also think it raises challenges for the funders of this kind of research and for the review panels. If we can't convince the review panels to really understand the need to do research with individuals with disability and multiple chronic conditions, no matter how good our proposals are, we're not going to get them funded. So it's really a challenge. So to achieve the goals of CER, from my perspective, and this is also Tonetti and Studensky, who are both prominent geriatricians in the field, they also shared this concern, and they wrote an article in the New England Journal just last year, and they said, CER must address the population that consumes the most health care. And as geriatricians, their focus was on patients particularly older patients with multiple chronic conditions, which account for over 80% of Medicare costs. And they're overrepresented in Medicaid and private insurance plans, but underrepresented in much of the research that is currently being done. So they argued, and as someone who's very interested in measuring outcomes of care being provided, I tend to agree with them. A fundamental question is how to define benefit and harm when multiple conditions exist. And we will be talking about that later today as well. And they argued we must move toward a focus on cross-disease or more universal outcomes in research. And they argued the consequences that matter most to patients are where we should be focusing, such as symptom burden, function, and health-related quality of life. And again, if you look at those outcomes and the importance of those outcomes to individuals with disability and the challenges in getting funding from federal agencies who fund this kind of research, particularly the NIH, we have a long ways to go. Other agencies like NIDR are much more comfortable in funding this kind of work, and I think we need to help the NIH to move forward in this area in the coming years. The federal government is into comparative effectiveness research in a big way, and I, for one, applaud this. I think it's very forward-thinking, it's very innovative. In the American Recovery and Reinvestment Act of 2009, there was over $1 billion put forth to support comparative effectiveness research. They created a council, a federal council on comparative effectiveness research, and they have been publishing work. And if you have the chance, go look at what they're writing. It's really interesting to see what they're putting out there with respect to comparative effectiveness research. And the IOM has gotten into this area as well. Then the Patient Protection and Affordable Care Act of 2010, they created the Patient-Centered Outcomes Research Institute, or PCORI. We have a representative of PCORI with us today who will be talking this afternoon as an independent, not-for-profit entity dedicated to the support of comparative effectiveness research, in addition to the other agencies like AHRQ, which also are here today, the NIH, NIDR, and other federal groups who already are interested in funding comparative research. So I think this is a time of tremendous opportunity for those of us who are interested in disability-related comparative effectiveness research, and there are resources being provided by the federal government to support that kind of work. I, for one, think it's unprecedented, certainly across my career, in the kind of money that is now available to do this kind of research. This federal agency argued that a national CER program, the Federal Council, said it must provide better evidence, so that's obvious and pretty straightforward, but also must improve the uptake of new knowledge and its translation into better decision-making, better care. This, again, is quite innovative if you take it seriously. We've been much better at developing new evidence and new knowledge and much less focused on the methods, techniques, and the science behind diffusing those innovations into practice. Practice lags behind new knowledge considerably. And so to explicitly include that as part of CER, I think, is really important. And to empower consumers and healthcare providers in a dialogue about their care decisions. Among the recommendations that the IOM said is that we must make research into methods of CER a priority. Again, I think this is really important. We'll be talking about it at the conference today, and they're explicitly acknowledging that we need to fund research on better method development. The CER program needs to help develop large-scale clinical and administrative data networks to facilitate observational CER research. I'm sure Ken Ottenbacher and his colleagues were very pleased to see that come out of the IOM report, as we all are. I mean, this is extremely important infrastructure that needs to be put into place in order to ask important comparative effectiveness research questions. Investing in the development of a research workforce with the skills to conduct CER. Again, this is critically important. We've seen that over the past 30 years as the NIH and other agencies such as NIDR, the VA, have invested resources into developing a cadre of researchers interested in doing this kind of research. This is explicitly being acknowledged by the IOM as an important priority that needs to go forward. And in addition, the IOM were so bold, and I would have loved to have been on that panel. They identified the top 100 high priority CER topics, and then they ranked them into quartiles. I can't imagine getting a panel to come to consensus around that kind of task, having been on IOM panels in the past. So my hat goes out to them. They were able to pull that off. The Federal Coordinating Council put together a framework that really encapsulates all that I've just talked about. They not only talked about priority populations, priority conditions, and types of interventions, but they broke it down in terms of comparative effectiveness research itself, the human and the scientific capital for CER and the importance of that, in addition to the research itself, the data infrastructure. No one likes to fund infrastructure. It's incredibly important, and they acknowledge this as an important arm of CER, and then the translation and adoption of CER. And we're talking about T3 and T4 translation, not the kind of stuff that most of the CTSAs do. They talk about translation, but it's all T1, T2. They're not serious about T3, T4 translational research. And what this group is saying is that real translation into practice and into communities is what needs to be done for comparative effectiveness research. So many people have questioned whether, what's new about comparative effectiveness research. From my view, if we really take it seriously, seems to me what the federal government and these organizations they have set up as saying is that we need to take seriously and invest into what needs to be done in order to move our research enterprise into asking the kinds of questions that will specifically address the quality of care that we provide, and then develop the infrastructure that we can really do that, the capital so we have the people to do that research, and then develop better techniques, better theory, better methods of implementing those findings into practice and transforming the way in which we provide care to individuals with disability. So I, for one, think this is transformational. At least it has the potential to be transformational if we take the opportunity, if we grab it, and which is why we were particularly interested in bringing you all together to do this conference. I just wanted to, near the end here, show this is what the IOM group did. The primary and secondary CER priority areas, they really did begin to very specifically outline them, and they focused on 100. I just want to focus on this one here, functional limitations and disabilities. If you look at primary and secondary, it was near the top, which I was really comforted to see. Not in terms of primary, so that's troubling, but certainly in terms of the combination, it's very near the top in terms of the 100 conditions. And then I mentioned that they did the quartile thing, and these are some of the ones that made it to the top quartile. So prevention of falls, comprehensive care coordination programs, both for children and adults with chronic diseases, prospective registries to compare treatments for low back pain. That one's for you, Tony. And then alternative strategies for detection and management of dementia. I mean, these are really important areas that made the top 25. And then, however, someone had to be in the lowest quartile, right? Some of these are troubling. Sorry, Bob, different treatment strategies for osteoarthritis. It was in the lower, it was at least in the 100, but it was in the lower quartile. But these are some of the others. These are incredibly important areas, but they didn't make the top quartile ranks.